ultra low-dose Nivolumab in relapsed refractory solid tumors, the DELII trial. Welcome back to Head and Neck Oncology Journal Club. Today, we are covering a trial that could reshape how we think about immunotherapy access worldwide. The paper is from Vanita Norona and colleagues from Tata Memorial Hospital in Mumbai, published in the Journal of Clinical Oncology. It's called the DELII trial, and the question is bold. Can you give 1/12th the approved dose of Nivolumab and still improve survival? Here's why this matters. The approved dose of Nivolumab is 240 mg IV every 2 weeks, costing approximately $5,000 a month. The average monthly income in India is about $175 to $233. At Tata Memorial Hospital, only 2.8% of eligible patients could actually receive checkpoint inhibitors. But the pharmacology suggests lower doses might work. PD-1 receptor occupancy of 70 to 75% is needed for immune activation. Even doses as low as 0.1 mg per kg achieve median receptor occupancy of 64 to 70%. The serum concentration needed for efficacy is just 1.2 micrograms per ml, while the standard dose achieves approximately 33.7 micrograms per ml. There's a huge therapeutic window that has been unexplored, and this same group had already shown in a prior randomized study that low-dose Nivolumab improved survival in advanced head and neck cancer, published by Patil and colleagues in 2023. The study design, DELII, was a phase 3 superiority trial. 500 patients randomized 1:1, ultra low-dose Nivolumab 20 mg IV every 2 weeks versus standard chemotherapy. Eligible patients had relapsed solid tumors including lung, head and neck, esophageal, bladder, and MSI-high tumors after at least one prior line previous treatment. The primary endpoint was overall survival. The population 82% male, median age is 49.5 years, 52% had head and neck cancers, 36% lung cancer, 77% were PD-L1 positive. The median follow-up was 28 months. The results: ultra low-dose Nivolumab significantly improved overall survival. Median overall survival 5.88 versus 4.70 months. Hazard ratio 0.8, P equals 0.022. 1 year overall survival was 27.3% versus 16.9%. All subgroup point estimates favored Nivolumab. Progression-free survival was identical between arms, 2.04 versus 2.09 months, hazard ratio 1.03. Response rates were similar at 7 to 8%, but the overall survival curves crossed for the first 2 to 3 months before separating, consistent with the delayed onset of ICI activity. This overall survival without progression-free survival benefit pattern has been seen before in Keynote 048, Keynote 010, and Checkmate 057. For our audience, the head and neck subgroup is the key. With 259 patients, it was the largest subgroup. Most had buccal mucosa and oral tongue primaries. The head and neck cancer subgroup hazard ratio was 0.86, consistent with the overall result, though not independently significant. Smokers showed a strong benefit at hazard ratio 0.62, P equals 0.004, and squamous histology favored immunotherapy at hazard ratio 0.78, P equals 0.038. On safety, grade 3 or higher adverse events were significantly lower with Nivolumab, 42% versus 60%, P less than 0.001. Quality of life was significantly better in the immunotherapy arm. The cost argument is straightforward. Nivolumab 20 milligram costs approximately $211 per dose. Standard Nivolumab 240 milligram costs about $2,520. Globally, 55% of new cancer cases and 64% of cancer deaths occur in Asia and Africa. For patients in low and middle income countries, this cost difference is the difference between having a treatment and having none. Important limitations of the study were that it was a single center, open label, mixed tumor types were involved, and critically, no comparison to standard dose immunotherapy. Here's the bottom line. Ultra low dose Nivolumab at 1/12th the standard dose significantly improved overall survival versus chemotherapy. Fewer severe toxicity, better quality of life. Over half the trial population had head and neck cancer with consistent benefit. For relapsed head and neck cancer patients where standard dose ICEs are unaffordable, this could open the door for immunotherapy where none was previously available. The unanswered question remains, how does ultra low dose compare to standard dose? But for the millions of patients with zero access to full dose immunotherapy, this could be transformative. The authors call for evaluating this approach earlier in treatment and in curative intent settings. That's your podcast summary. The full citation and links are in the show notes. Until next week, this has been Head and Neck Oncology Journal Club. Thank you.